you very much. Thank you for inviting me to give this talk. I'm very sorry we're not all face to face and having fun like we've done in previous John Price meetings, but I'm sure in a year's time we'll make up for lost time and have a more social time. But thank you for inviting me. I've been asked to talk about should salbutamol be a controlled drug, or as I prefer, it's time to red card the blue inhaler. So I have no perceived or actual financial conflict of interest. I am a member of the NICE Asthma Treatment Guidelines Committee, a very egregious poacher turned gamekeeper, but these views are my own views and do not reflect what NICE think. So the aims of my presentation are to discuss the reasons why children have repeated asthma attacks and die of asthma. I hope to demonstrate that short-acting beta agonists are dangerous and we need to think about combination rescue therapy for children with asthma instead. I will review the expanding data set in children and adults that this new approach is more effective. And so I'm going to talk about Ban the Blue Inhaler. And like all the best children's stories, once upon a time, this was about a celebration. This is Alice and her boyfriend. She's 19. She's peanut allergic. She goes with her boyfriend for an anniversary celebration meal, and 45 minutes after leaving the restaurant, she collapses and dies, despite the fact the boyfriend very efficiently administers the adrenaline injection. There's an inquest, and in the past year, it transpires she's picked up 19 salbutamol inhalers, a total of nearly 4,000 activations, and only 2 months' supply of severity inhalers, 2 out of the 12 months that she needed. And the inquest verdict was asthma death. And this, I'm afraid, is not an uncommon scenario. So why do people get asthma attacks? What are the risk factors? This was a systematic review carried out under the auspices of the Asthma UK Centre for Applied Research. The 16,000 plus records were identified, and eventually 68 papers could be reviewed. And these are the findings. So the risk, red is greatly increased, no effect is green, and the bigger the circle, the more confident that you can be. Sorry. There are regional differences. Noticed an African American race in the US, poor access to care. This is a factor in the US, but we don't have data from other parts of the world. And unsurprisingly, beware if you've had previous asthma attacks, symptoms, ongoing chronic symptoms, or suboptimal treatment. And particularly note increased short-acting beta agonist use and suboptimal inhaled corticosteroid usage. And this was published a couple of years ago in Thorax, and the findings confirm what many individual studies have shown. So what actually are the data? So this is Sammy Sweeter's work in the New England Journal of Medicine many years ago, and on the vertical axis is the risk ratio for asthma death. On the horizontal axis, the number of canisters of inhaled corticosteroids per year, and the fewer you access, the more likely you are to die. Here you can see the short-acting beta agonist use. Again, old study, 25 years ago. Ignore phenoterol because this study was published at the time of the New Zealand asthma phenoterol asthma attack deaths. Look at the albuterol or salbutamol. The more canister units per year, the more likely you are going to have a bad attack and die. This is no surprise. There are multiple other papers that say the same thing. And this is the National Review of Asthma Deaths, perhaps one of the most depressing documents I've ever read because it's the same as the one before and the one before that. Around half of all deaths were in so-called mild asthma, which is, of course, a contradiction in terms. Many were not under specialist review, and overuse of short-acting beta agonists and underuse of inhaled corticosteroids were all too common. This is the Lancet Asthma Commission that I was privileged to co-lead with Ian Pavord, and one of the things we wanted to highlight, we should have a zero tolerance of asthma attacks. We should not tolerate an asthma attack. An asthma attack should be a never event, like chopping off the wrong leg in surgery. And a paradox, you'll be relieved to hear I'm not about to sing the Pirates of Penzance, for those of you who recognize the quotation. On the right, you'll see the BTS Sign Guidelines. Step one in this and hitherto virtually every guideline, as requires short-acting beta agonist, switch to step two, inhaled corticosteroids if you're using the SABAs for more than 3 times a week, or fit in any arbitrary numbers you like. But we're quite happy, just use short-acting beta agonists. Step two and above must use regular anti-inflammatory steroids. You must not use long-acting beta agonists as solo agents. But pray tell me, what is the difference between using long-acting beta agonists as solo agents and multiple doses of short-acting beta agonists as solo agents? You tell me, and then we'll both know. Step two and step one are polar opposites. So what are the problems? One of them is we have totally failed to sell adherence to inhaled steroids to the public, and there's little sign this is going to change anytime soon. Anybody who thinks that with social media and Twitter and e-alerts and stuff like that is going to change adherence, take a look out of the window and look at that pink thing flying past the window. It's not going to change. We use electronic monitoring as a routine part of our assessment of severe asthma. It only checks whether medications are taken, not whether it doesn't check if they've been taken, only checks activation, but not inhaler technique. In this study by Anya Yokman, nearly 100 children were monitored for a median of 3 months. They knew they were being electronically monitored. We told them we weren't trying to catch them out, and about 2/3 did not adhere to their inhaled steroids, even knowing they were being monitored. Goodness knows what adherence is like in the unmonitored population. We have also totally failed to sell the seriousness of short-acting beta agonist overuse to the asthma caring community. NRAD identified high prescriptions, a factor in 40% of deaths. Rates of admissions rise if you're prescribing more than 3 canisters a year. Morbidity and mortality rise progressively with increasing numbers of canisters. So Sean McKibben, a PhD student in the Asthma UK Centre, interviewed asthma experts from hospitals, primary care and GPs delivering asthma care to see how they defined short-acting beta agonist use. It would be interesting if we were face-to-face to run a straw poll of what you think, but the definition was overused. It varied between 100 doses per year to 12 canisters, 2,400 doses a year, or 200 doses per month, or 6 or 7 doses per day, every day. That was thought to be okay by some. What did they say? GPs in their heart of hearts know that patients shouldn't have too many SABAs, but they really don't know what too many is. Some experts questioned whether there was a real risk at all. Asthma guidelines were deemed stringent by one expert. So we'll have asthma guidelines so long as they don't make us change our practice at all. Another guideline recommended as silly. Another said guidelines didn't reflect the real world and that SABA prescribing was unlikely to change until someone can prove the patient is at increased risk. And at this point, I was about ready to cut my throat, because if you won't believe that amount of evidence, God help the lot of us. So what are the data suggesting we can do better? They're not taking their inhaled steroids. They're taking shed loads of short-acting beta agonists. They're having attacks. Some are dying. Can we do better? So the first study was Trexa, led by Fernando Martinez, and they looked at nearly 300 children and adolescents with mild persistent asthma, and they had 2 canisters. The regular BDP canister that dispensed 40 micrograms of puff. The as needed 80 micrograms, and they randomized their patients to one of 4 groups. The first group, they used twice daily beclomethasone and the combined beclomethasone salbutamol inhaler as reliever. The second had standard step 2 treatment. They had twice daily beclomethasone and as needed salbutamol. Group 3 had twice daily placebo and a rescue inhaler combined steroid and beta agonist. And group 4 had standard step 1 therapy, as needed salbutamol. So what did they find? So here's the time to first asthma attack, and you can see that the placebo group were much more likely to get an asthma attack than any of the other 3 groups. The other 3 groups were statistically identical. Here, if you look at treatment failure, the chance of treatment failure was much greater with the placebo group than with any of the other 3 groups. And the placebo group, I'll remind you, is standard step 1 therapy. Standard step 1 therapy did less well than standard step 2 or using the combined inhaler. What about safety? Because I can hear people saying, oh, well, you use the combined inhaler, that just meant they shed loads more steroids. Well, they used linear growth as a surrogate. They didn't have a dose counter, and you can see that linear growth was better in the placebo group, and it was equally good in those who had twice daily placebo but rescue therapy with inhaled corticosteroids and salbutamol combined. The other 2 regimes, with regular beclomethasone, there was an impairment in lung function. Growth as a surrogate is not the same as dose counters, and they had better linear growth with beclomethasone as needed than with regular beclomethasone. And this is nearly 10 years old in the Lancet. Now, a lot of us are using the SMART regime, a combination of budesonide and formoterol, a single inhaler for maintenance and reliever. I use it a lot in adolescents in the hope that given one inhaler, they'll remember it. It's once or twice daily in varying doses and for relief. And Gina hitherto recommended SMART at steps 3 to 5. And this is a meta-analysis of 6 RCTs in nearly 2,000 patients aged 12 to 17. And the primary endpoint was time to first attack. And what you can see here in the adults in red, adolescents in adolescents in blue, and you can see that the adolescents with the SMART regime, they had a longer time to first attack. The summary is circled, and if you look here, the number of severe attacks was also better in those who had the SMART regime compared to those with standard therapy. There is but a single trial in the 6 to 11 age group. In this case, budesonide formoterol once daily and as needed versus twice daily budesonide formoterol versus a big dose of budesonide. These patients had to have at least one serious attack in the previous year and be prescribed inhaled steroids. And the SMART regime reduced attacks significantly. And if you look here, the dark gray is the SMART regime. There were fewer exacerbations of all sorts, fewer falls in peak flow, fewer needs for extra treatment, and fewer hospitalizations with the SMART regime. And this was published in Chest. And this is similar to the meta-analysis data in adults and older children. So let's look at some new studies. This is Sigma. This is a 52-week double-blind randomized controlled trial in above 12 years of age. Twice daily placebo and as needed terbutaline, standard step 1 treatment. Twice daily placebo and as needed formoterol budesonide, the SMART regime. And twice daily budesonide and as needed terbutaline, standard step 2 therapy. The primary endpoint was electronically recorded weeks of well-controlled asthma. And also published was Sigma 2, again a 52-week double-blind study. Again, in this case, they compared the SMART regime with standard step 2 therapy. Prevention of severe exacerbations was the primary endpoint. So Sigma 1, what did it show? And this is the unfortunate thing, like it or not, twice daily budesonide was best for control compared to the other 2 regimes. And it is on the basis of these and other data that EMEA, in my view, in an act of stupendous folly, have refused to license this approach. There was no difference in terms of attack rates, either severe or moderate attacks rate. In each case, the terbutanin is needed with worse. But interestingly, those with the SMART regime used much less inhaled corticosteroid, 57 versus 340 micrograms per day. In Sigma 2, equivalence for prevention of attack, and you can see that as needed versus maintenance, the prevention of attacks or severe attacks was equally good. Again, the step 2 had better symptom control, not by very much. You can see the asthma and ACQ fell in both. And again, the as needed regime had much lower use of inhaled corticosteroids. Now, this was a real world study. The Sigma studies, each patient had every inhaler, so they had a multiplicity of inhalers. And this took the complicated assessing adherence. This was nearly 700 adult patients with mild asthma, and they were given either step 1 treatment, step 2 treatment, or as needed, inhaled steroids LABA rescue therapy. It was not blinded. They looked at annualized attack rates, and it was worse in the step 1 treatment. The other 2 groups were the same. But most importantly, the severe attack rate, remembering it's severe attacks that are most predictive of asthma deaths, the budesonide formoterol rescue group, as needed, was in the blue, is most effective in preventing severe attacks. And they used a lower inhaled corticosteroid dose by about 50%. Other studies, the practical study, adults, doctor-diagnosed asthma, on those who they could have inhaled steroids, they were randomized to as-needed budesonide formoterol versus standard step 2 treatment. Primary outcome was number of severe attacks a year, and again you can see in the blue group, those with regular in fact had more attacks. Time to first or moderate or severe attack was worse in those with standard step 2 therapy, as needed did better, and budesonide formoterol was more effective. This is the ASSIST study, the only pediatric study in African American children, randomized to standard step to as needed beclomethasone and short-acting beta agonist. This is a North American study, and you'll remember they're all paranoid about the safety of long-acting beta agonists. And this was compared to standard provider-based management. They had an inhaled dose counter, and the primary endpoint was asthma control. And you can see provider-based management did have slightly better control, but really not clinically significant, big overlap. In the younger children with the C-Act, absolutely no difference. And confusingly, they've swapped colors. Those with the as needed beclomethasone used less beclomethasone than children on the standard step 2. And this was a qualitative study was performed in another paper, and this was well received by families. So Gina, this is the new guidelines, number of different things which I'm not going to touch on, but the main thing Gina are now saying in step 1, and thereafter we should be using as needed low dose inhaled steroids formoterol and not using short-acting beta agonists. So, summary, unanswered questions and conclusions. Should we ban the blue? Well, the unanswered questions, we clearly need a real-life pediatric trial urgently, along the lines of Richard Beasley's New England Journal of paper at all levels of eosinophilic asthma severity. Do they do better with inhaled salbutamol for rescue or combination beta agonist inhaled steroids for rescue? We don't know which is a better bet, whether inhaled steroids and short-acting beta agonists, which is what the American market will want, or inhaled steroids long-acting beta agonists. And I'm well aware, of course, that in a low and middle income setting, price is going to be a very important issue. We're going to need to adapt our asthma plans to give a threshold for seeking care, perhaps saying if your rescue inhaler has given you more than 800 micrograms in 24 hours of beclomethasone, then you need to seek help. And this is a real revolution because many of us have been taught to prescribe 10 puffs of salbutamol 4-hourly. Well, I'm not convinced that there's any safety data for that. And I'm not convinced that, in fact, we should be using nearly as much as we seem to be doing as a routine in asthma care. And of course, there are areas where solo SABAs are legitimately prescribed for non-type 2 inflammation, such as episodic viral wheeze, in the adults with COPD, but we need to find a way of keeping them out of the hands of school-age asthmatics. I'm puzzled by this suboptimal symptom control. Why they didn't take more treatment? But I think we do need to persuade the regulators that something has got to be done. So 4 trials in more than 10,000 patients have failed to show any benefit of SABA monotherapy in children with asthma of 12 years age and over. We have failed to sell inhaled steroid adherence, and we are not going to succeed. Sorry if that sounds defeatist. The reason it sounds defeatist is because I am defeated. We have failed to stop negligent and reckless prescribing and use of short-acting beta agonists. And again, there is no sign that either of these is going to change anytime soon. Both poor inhaled steroid adherence and overuse of short-acting beta agonists are important factors in asthma deaths. And if the blue was banned, this would be preventable. And I would leave you with the question, if we have 2 options, namely short-acting beta agonists flying solo or combination beta agonist inhaled steroids, if we have 2 options available and one, like short-acting beta agonists, has a safety cloud hanging over it, why would we not use only the safety option? And it was just this reasoning that persuaded the great Helen Clark, when she was New Zealand Health Minister, to save multiple lives in New Zealand by banning the phenol aerosol. So I'm going to leave you with a Valentine's Day card that I received from an anonymous admirer, perhaps the only one. And this is the blue inhaler. You take my breath away, and I hope I've shown you that that may be literally the truth. And my own known admirer said, "Dearest Valentine, we belong together." And I would put to you that beta agonists and steroids belong together and should not be separated, or perhaps death literally will part us. Thank you very much for your attention.
Thank you very much, Andy, for the excellent talk. Seb Gray has asked, do you think there is a current evidence to support smart use in those with under 12 years of age? If so, what do you use? And if not, what are the alternatives?
So there is that one study that I showed you, the Hans Bisgaard study, that showed in the 6 to 11 age group that SMART was effective. So there is that one study. One would rather have more and a bigger study. I do think, as I stated, we need a proper pediatric study. 12 and over contains lots and lots of adults. We need the pediatric study. But I think in real life, parents are doing SMART with families. I bet you that parents, when their kids are better, stop using the inhaled steroid treatment. We're just formalizing what is really happening in real life. So yes, there is evidence in the 6 to 11 age group, not as good as in the 12 and over, but there is evidence to do it if you think you need it. Of course, in the 6 to 11 age group, you've got to make sure very carefully that they can use the turbo inhaler if that's what you're going to prescribe.
And Andy, at what would you peak? So for 12 and above, some people give up to 8 additional puffs. How much would you limit at between 6 to 11?
I think that's a very good and important question. Completely arbitrarily, I would say if you've used more than 6 puffs in a day, you probably need to seek help. We do need to modify our asthma plans, and that's work that still needs to be done. The number is arbitrary, but that would be my arbitrary number at the current time.
Andy, another important question. So based on your talk and the evidence you have shown you have convinced that it is a common sense to ban blue. So is the government aware of these findings, and what are the national agencies are doing about it?
Well, I'm afraid the national agencies are not convinced. The European Medicines Agency says, control is not as good with this combined approach. We're not going to approve it. Now, I would not in any way underestimate the importance of asthma control to quality of life, but people don't die of poor control, they die of asthma attacks. I think before we ban the blue in the 5 to 11-year-old group, we do need that study. I think we do need a pure pediatric study, 5 to 16, and some of us are trying to set that up at the moment. But certainly for 12 and over, I have to ask myself, what is the justification for giving short-acting beta agonists? I come back to the tragic case of that young girl who died. If she'd not been able to access salbutamol as a solo agent, would she have been alive or not? I suspect the answer is she would have lived.
And in the very debated questions, and is something which is again poor evidence based. How would you recommend weaning salbutamol nebulizers to inhalers? We generally suggest changing to 10 puff of salbutamol every 4 hourly, and then wean over next 2 to 5 days at home.
So this is a different area and a very important one. Is there a role for a weaning pattern for salbutamol? And I would like to quote to you the Hilaire Belloc, who wrote various rhymes that you should read. His poetry is excellent. Hilaire Belloc said, "Let no one ever doubt what nobody is sure about." And the weaning regime of salbutamol is handed down as gospel from non-evidence-based paper to non-evidence-based paper. There is no data supporting it. The real worry, if you have a so-called weaning regime, is you may mask that asthma is getting worse by giving these huge doses of salbutamol. So I'm very unconvinced that a weaning regime is the right thing to do. Louise Fleming, I don't know if she's on this call, but Louise Fleming tried to get a study done across London to test this and couldn't get funding for reasons that escape me. Weaning salbutamol is part of the gospel the gospel of asthma, but there's no justification, no evidence. I will retort, why do we do it?
So, thank you, Andy. Sarah is asking, presume it is not to be okay to use seretide with the spacer at SMART in 6 to 11 years of age.
That's a really important point to make. Seretide contains salmeterol, which is a partial agonist and has a very flat dose response curve and a slower onset of action. So yes, you're quite right. Seretide should not be used as part of the SMART regime.
Indu Khosla from India, excellent talk, Andy. In a country like India, where asthma is not so severe as you see in UK, what do you think we need to do? Do we need a combination instead of only SABA inhaler?
So this raises a really important point, that one of the reasons I find the umbrella term asthma not a useful one is the asthma that you see in India the same as the asthma I see in London? And only Indian pediatricians can answer that question. If you are seeing a lot of atopic allergic eosinophilic asthma in India, then I think you need to be using the combination inhaler. But for example, to take an example, if you look at Renato Stein's paper from Porto Alegre in Brazil, he is seeing a very different set of asthmas. He sees much less atopic asthma, a lot more parasite infections, a lot more viral infections, possibly a different disease from what I see. So for those of you around the world listening, don't please assume that the asthma that I see in London or Atul sees in London is the same as you are seeing in Mumbai or Porto Alegre or Cape Town. It may be a different disease, and you need to characterize what disease it is.
Thank you, Andy. And then the very important questions: how do we ensure that the same message is given by the emergency department clinician. The pressure on discharge involves high doses of salbutamol, and parents always remember this.
I think that's a very, very good question. It took a long, long time before the unequivocal evidence that metered dose inhalers and spacers were at least as good, if not better, than nebulizers actually filtered through to emergency doctors. I think one of the problems that we've got to get across is that an asthma attack is not a trivial event like slipping over and your trousers splitting out the back. You can get that, you can put that right. An asthma attack is a sign of trouble ahead. And too often, well, NRAD identified that the frequent flyers in accidents and emergency were the ones that died. They rocked up, they got a 3-day or 5-day course of prednisolone, they got a load of salbutamol, bye-bye, everything will be fine. Well, if you see a child with a real asthma attack, as sure as God made little apples, that child will have another one and another and another, unless you find out what went wrong and do something to put it right. Is there an asthma plan? Was it followed? Does it need to be changed? It should be a really serious red flag, a wake-up call, and it's not treated that way at all.
Thank you, Andy. 2 more questions, and then we close. Mudhir Gopi, excellent talk. Before we have evidence in weaning regime of salbutamol, both in the hospital and community, do you think is there a benefit of having a consistent approach so the parents don't get confused with the varied practice?
I absolutely think that's right, and that the more different approaches that there are, the more confused patients will be, the more they'll likely pick and mix what suits them rather than what is actually factual and evidence-based. Yes, we need to get, and going back to the previous questioner, we need to have the same approach in primary care, in secondary and tertiary care, in emergency room settings, all across the board if we're going to make progress.
And the final one from Albert Lee. How about another inhaled corticosteroids apart from budesonide plus formoterol? For example, fluticasone, which is fluticasone plus formoterol.
So didn't cover, there is no particular reason why it should be beclomethasone or budesonide or any cheap and cheerful inhaled steroid combined with a short-acting beta agonist. What I didn't touch on is one of the things, if I've got really recalcitrant adolescents who don't respond to a SMART regime, I give them the once daily combination Relvar of a long-acting steroid and a long-acting beta agonist. Say take this once a day and have rescue SMART as well. That's my second line. But there's nothing special. I mean, the formoterol budesonide just happens to be there. It's what we've used. It's what we've got most experience in.
Brilliant. Thank you very much, Andy.
Thanks for your attention, guys. Enjoy.
Now, moving on to the next talk. The next talk is about what is currently people want to hear a lot is about COVID-19.